What is the essence of critical care? Checking cardiac output? Monitoring vital signs? Measuring intake and output? Pain control? Proper position of the patient? Managing medication?
Actually, the essence of critical care involves all of these. While critical care nurses carry out these tasks routinely, the purpose of this presentation is to help you keep in mind the bigger picture. The essence of critical care is maintaining the balance between oxygen supply and demand for the patient as a whole. Hi, my name is Doris, and I'm the Director of Nursing for CMC. The goal of keeping our patients' oxygen supply and demand balanced is to improve patient outcomes, and good patient outcomes are what we as nurses are all about. This presentation is part of the CV Nurse course at CMC. For the next few minutes, we will try to capture the essence of critical care for cardiac patients.
For most open heart patients, this can be boiled down to hemodynamics and hemostasis. If you wanted to just give the bullet when you're reporting on your patient in the ICU, for example, you might say something like this. The cardiac output is 3.1 liters per meter squared per minute, and the chest tube drainage for the past hour was 80 cc's. That would tell me a lot about oxygen supply and demand. But let's talk about the determinants of total body oxygen supply and demand. Supply is the amount of oxygen delivered to the tissues, especially the brain, heart, and kidneys during periods of stress. Oxygen demand is the oxygen consumption by these tissues. Oxygen supply to the body is a simple equation. It's the cardiac output times the oxygen content of the blood, which equals the amount of O2 delivered to the tissues. The cardiac output is the amount of blood pumped expressed in liters per minute. The cardiac index is normalized to body surface area. The oxygen content of the blood is the number of milliliters of oxygen per milliliter of blood.
Hi, I'm Phil. I'm a CT-ICU nurse at CMC. You may remember from nursing school, cardiac output equals heart rate times stroke volume. Another way to determine cardiac output is the heart rate, rhythm, preload, afterload, and contractility. Therefore, the last four must determine the stroke volume. What is the optimum heart rate? Well, the normal heart rate is 60 to 100 beats per minute. Sometimes when we're trying to maximize cardiac output, especially for someone with a weak or failing heart, we try to shoot for the upper end of that spectrum, 80 to 110 beats per minute. What is the optimal rhythm? Well, normal sinus rhythm is the best because it maintains atrioventricular or AV synchrony. First the atrium beats, then the ventricle. Lub-dub. The next best rhythm would be A-paced. Pace the rhythm, then the normal conduction system carries it through to the ventricle. After that comes AV paced, then atrial fibrillation with a normal ventricular response. Then there could be other rhythms with a ventricular rate less than 60 or greater than 100. Then the worst rhythms would be ventricular tachycardia and ventricular fibrillation. These rhythms simply cannot maintain a normal cardiac output.
Let's talk preload. It's the amount really of sarcomere stretch at the end diastole. Well, that sounds a little esoteric. That goes back to the Frank-Starling equation, and that's not something we can measure clinically. So how do we work our way to something we can measure? Well, instead of the sarcomere length, we could talk about left ventricular end diastolic dimension, sort of a research lab measure. We try to substitute left ventricular end diastolic pressure, and remember that pressure and dimension are related by something called compliance. So if you hear heart surgeons or cardiologists saying a ventricle has good compliance or poor compliance, they're talking about the relationship between pressure and stretch. You can measure the left ventricular end diastolic pressure with a catheter in the ventricle as they do in the cardiac cath lab, but we don't usually do it in the operating room or the ICU. So we take another step backwards to the left atrial pressure. And in fact, in children, that's what's most often measured. We simply leave a catheter in the left atrium at the end of an open heart operation. We sometimes do that in adults, but usually we take another step or two backwards and we use a pulmonary artery catheter. If you wedge the pulmonary artery catheter and there's no transpulmonary gradient, it should reflect the left atrial pressure. But we don't wedge the catheter too often, and instead we substitute the pulmonary artery diastolic pressure. So keep in mind how many steps backwards we're measuring when we talk about preload, and we talk about preload of the left ventricle as being the pulmonary artery diastolic pressure. For the right ventricle, it's a little simpler. We measure the right atrial pressure, or the CVP, central venous pressure. The higher filling pressure determines the rate-limiting ventricle. So, for example, if the cardiac index was low and the pulmonary artery diastolic pressure was 12, but the CVP was 24, we would say that the right ventricle would be the rate-limiting ventricle, the one that's challenging the heart in terms of cardiac output. Afterload is the resistance which the heart has to work against, or the systemic vascular resistance. That's mainly determined by how tight your arteries are. But it can also be due to obstructive lesions, such as aortic stenosis, idiopathic hypertrophic subaortic stenosis, or IHSS, or coarctation of the aorta. Contractility is the forcefulness of the contractions. This can be manipulated with inotropes, usually catecholamines, epinephrine, norepinephrine. And why do we reach for these drugs last when we're trying to manipulate cardiac output? Well, because they increase myocardial oxygen demand. And as critical care specialists, we are concerned about the balance of oxygen supply and demand for vital organs such as the heart.
Let's talk about the oxygen content of the blood. 99% of oxygen is carried by the hemoglobin. So the oxygen content of the blood is determined by the hemoglobin concentration and the oxygen saturation. Oxygen is directly related to the PaO2, or the partial pressure of oxygen in the arterial blood. So we impact oxygen delivery by manipulating the cardiac output and the oxygen content of the blood. For example, we adjust the heart rate, rhythm, preload, afterload, and contractility in that order, mainly by using drugs, pacemakers, intravenous fluids, and transfusions. We try to adjust the oxygen content of the blood by assuring adequate PaO2 and adequate hemoglobin concentration via changing the inspired oxygen concentration, changing the ventilator settings, removing obstacles to ventilation, such as secretions or effusions, and using blood transfusions, but only if absolutely necessary.
So how do we know if we've succeeded? How do we know if we've done a good job in assuring the adequacy of oxygen supply? We'll answer that question in a minute. But first, regarding oxygen demand of the body, most of the story is told through the patient's vital signs: temperature, heart rate, blood pressure, and respiratory rate. If the temperature is too high or too low, the patient may have rigors or shivering, which increases the oxygen demand. If the heart rate or blood pressure are too high, that increases myocardial oxygen demand, and in turn, whole body oxygen demand. Multiplying heart rate times blood pressure is the so-called rate pressure product. The respiratory rate reflects the work of breathing, or how much energy the patient is expending to ventilate himself. The respiratory rate can also influence the patient's ability to maintain adequate oxygen saturation. So how can we control the oxygen demand of the body? We do this by maintaining normal body temperature and avoiding vigorous muscle activity, including shivers, seizures, or agitated movement. We also try to maintain a low work of breathing and keep the rate pressure product within normal range. In other words, we are striving for a calm, non-agitated patient. So remember that question we asked earlier about evaluating our success in maintaining the balance of oxygen supply and demand? We can tell based on how happy the end organs are. The adequacy of brain perfusion can be measured through INVOS monitoring and the patient's mental status. Renal perfusion is reflected by urine output and the acid-base balance. With regard to the heart, we look at EKG, cardiac enzymes, and cardiac function to tell us whether myocardial oxygen supply and demand are well balanced. There are some other tools we can use to measure oxygen balance. Sometimes we use an oximetric pulmonary catheter to measure the mixed venous oxygen saturation. This should be above 60%, assuming there is no shunting in the periphery. For example, a patient with sepsis may have a high degree of shunting and have a falsely elevated mixed venous oxygen saturation. One can measure a mixed venous oxygen saturation without an oximetric catheter by drawing a blood gas slowly from the tip of a conventional pulmonary artery catheter. Some clinicians order lactic acid levels. When the body's oxygen supply and demand are not well matched, the tissues shift to anaerobic metabolism, and produce lactic acid. Even with all these tools, there is still no substitute for a good old-fashioned nursing assessment, especially outside the ICU. I could ask myself, how's my patient's mental status? How is their breathing? What is their skin temperature? How are their pulses? Do they have adequate urine output? When many of these are abnormal, we are often dealing with acute decompensated congestive heart failure, a common problem right after open heart surgery.
When the kidneys think the patient is dry and the lung thinks the patient is wet, that's congestive heart failure until proven otherwise. About a third of open heart surgery patients have some manifestation of CHF postoperatively. How do we effectively manage CHF in the hospital and immediately after discharge? Well, daily weights is one of the most important things. And sometimes they make fun of me and they say without them there is no program, but it's one of the things that we do well that makes it better for our patients and easier to care for them. We measure the intake and output carefully. We look at the oxygen requirement of the patient. We look at their ability to ambulate, their overall functional status. And then when they leave the hospital, we try to do careful follow-up. Heart failure patients must be contacted within 48 hours and seen within a week of discharge. Otherwise, they're doomed to readmission. Let's look at our readmissions. CMC open heart patients have extraordinarily low rates of readmission to the hospital. Readmissions are delayed complications. And if we're working on the complications in the hospital, we should be working on the complications immediately after they leave the hospital as well. In the last year, only 4% of all open heart patients were readmitted, and for coronary bypass surgery, it was less than 2%. When we compare our outcomes to the STS national database, we can see that the mortality rate at CMC is about half the national average, our mean length of stay is lower, and our readmission rate is only about 1/3 of what the rest of the country is experiencing. In summary, if we keep the balance of oxygen supply and demand in mind, we are delivering the essence of critical care. Our attention to detail distinguishes our heart program from others in our region. And how do we measure our success? It's measured in the outcomes and the number of patients who are home, alive and well, after heart surgery at CMC. Thank you for this opportunity.
We are so proud of our team of nurses at CMC and appreciate all you do for our patients. Through this presentation, we hope you keep in mind the essence of critical care as you continue to do what you do so well. Thank you.